Thank you, Becca.
Okay, thanks for coming back, everyone. I'm Becca, I'm an R2, and I'm going to be doing a talk on hospice for the IM resident, and this is really from sort of an ambulatory care setting, not really from the inpatient setting. Okay, our objectives today. One, we will be able to identify hospice eligible patients from the primary care setting. Two, we'll be able to counsel people on the nuts and bolts of hospice care. And three, feel comfortable, hopefully serving as quote unquote attending providers for patients who enroll in hospice. And kind of like Jen's talk, this is not a talk on how to have a conversation about transitioning someone to hospice. And then I'm also hopeful that this talk will be useful for people going into all sorts of specialties, especially ones with a large outpatient longitudinal component. So that includes cardiology, hepatology, hemonc, even rheumatology, and some other subspecialties. Please feel free to use the chat. I'm going to be peeking at it from time to time, or just unmute yourselves. The beginning of this talk is pretty interactive. Okay, let's get started. So just opening it up very broad, I'm wondering if anybody can either unmute themselves or use the chat and just define hospice. And don't be afraid.
End of life care.
Okay, Kevin, I heard you. End of life care.
Care that's more focused on symptom management rather than sort of treating illnesses.
Yeah, definitely. So care that's more palliative rather than curative or disease modifying. That was Emily. Great, thank you.
Yeah, like focusing on comfort rather than prolonging life.
Yeah.
Optimizing life now.
Yeah, so sort of care that's focused on palliation. Okay.
I always also kind of think about it in the sense that someone has to have a illness that one would reasonably expect them to pass within 6 months. And so sometimes hospice care, it makes me realize that sometimes we can enroll folks in hospice care a little bit earlier than we might think. It doesn't have to be right at the very, very end of life, like Jen's talk mentioned.
Yeah, Inga, you're like a plant. So you're kind of hinting at kind of who is eligible for hospice. So people whose disease course, if it runs a natural way, will have less than 6 months. Great. I love all those answers. Thanks for joining in, people. Okay. So I think like the biggest misconception about hospice, and I definitely was one of these people for a long time, is that hospice is this magical place that people get whisked away to when we decide that maybe their options are limited, or they're about to enter the dying process, or they have less than 6 months to live. And so we're like, cool, this person's gonna go to hospice. And that's really not the case. That's not really what hospice is. I think this misconception, at least for me, was really solidified on some of my rotations like hemonc when someone decided to go to hospice. Cody, can we build that though? On hemonc, when people decided they were going to go to hospice and the social workers came in and they kind of take them someplace, it was a little bit confusing to me. So definitely hospice is not a place. It sometimes can be, but it's not this big magical place. It is basically, to be pretty granular, it's a bundle of services that's paid for by insurance, and that's provided by a hospice group. And here in Seattle, we often partner with Providence Hospice. They're the people we work with probably most often. And so really what it is this bundle of services. It includes an interdisciplinary care team, which we'll talk more about, oftentimes pretty quick access to medical equipment. This includes assistive devices and beds, palliative medications. I think a lot of people mentioned that, Kevin, Annie, Emily. And then sometimes, although I said hospice is not a place, sometimes insurance will cover very short inpatient stays at either hospitals or nursing care facilities for symptom management, or for relief for caregivers if for some reason someone's caregiver is going away and they need a little bit of respite care. That can sometimes be paid for, but pretty infrequently. So most often it's a service that is provided at home. Okay. So let's get started with a case. So I'll read it for you guys, and then we'll have a question on the next slide. So Sybil is a 65-year-old woman with a history of insulin-dependent diabetes, obesity, AFib, and HFrEF, who comes to your clinic. She had CRTD placed last year and has been on maximal medical therapy. She's been hospitalized 3 times in the last year for decompensated heart failure. She can walk only very short distances, needs assistance with most ADLs, and requires continuous supplemental oxygen. So I think a lot of us can probably imagine a patient like Sybil. And so the question I have for you guys is, what do you do with Sybil? You A, refer her to UW Advanced Heart Failure Clinic for consideration of LVAD placement. B, she's not an LVAD candidate, so you discuss enrolling in hospice. C, she is candidate for both LVAD and hospice, so you discuss both with her. And then D, she is neither a hospice nor LVAD candidate, so you refer her to mental health to aid in coping with her serious illness. And I can go back to the previous slide so you guys can see the question stem again. We can give you guys like 30 seconds. And then Lauren, I guess you can let me know, or Javel, when it's like halfway filled up.
I'll show you when it's close. People are still voting. All right, got a good number of responses. So you should see the answers.
Okay, great. Wow, you guys are great. You don't need me. Okay, so I'm wondering if somebody can unmute themselves or type in the chat box. Someone who chose C, which seems like the most, I guess, the most popular choice. Who chose C, and kind of like what made you choose that answer choice?
I'm by no means an expert on what qualifies someone for LVAD versus not, but just looking at her age, she's 65. The number of comorbidities there with her EF don't immediately tell me this person could never have a bridge to something like transplant, which would be what the LVAD would be for. So I didn't want to throw that option out entirely, but also there are plenty of people who are like, I don't want to go through the whole terrible process of getting a massive pump shoved into my chest that I then have to worry about for the rest of my life, potentially. So I feel like both options would be reasonable to talk to her about, because she might have a long time to go, and hospice may or may not be appropriate. I can think of plenty of Harborview patients with an EF less than that who just seem to survive despite the odds. So that was my back of the envelope thinking.
Yeah, Alex, thank you so much. That answer is really thoughtful. I totally agree with everything you said. And I chose this case because I think we have a lot of patients like Sybil who have these complex medical problems for which advanced therapies are probably available, but who we also wouldn't be surprised if they had less than 6 months to live, and who also, right, like you said, might not want an LVAD. This is not a talk on advanced heart failure by any means, but I think it's useful to think about, kind of like Oyinka said, someone doesn't need to be in the last days of their life for you to be thinking about hospice. And for patients like Sybil who have advanced heart failure, we probably should be thinking about hospice a little bit more frequently. Okay, any other thoughts from people who chose C, or any of the other choices? Okay, we can keep going. All right. So I think Oyinka mentioned this a little, so I won't make you guys talk more right now, but she mentioned that people are eligible for hospice who have thought to have less than 6 months to live if their disease runs its natural course. And so I'm just wondering for you guys if you feel like there are certain disease processes for which prognosis feels challenging. And you can type in the chat or unmute yourselves. Everything, says Kim. I agree. I think you're right, Alex, that we're not so good. Dementia, great. Heart failure, especially very low EF. Yeah, some people can like kind of hang on for a very long time. Similarly with cirrhosis, I totally agree. And these are the things that we as internal medicine residents see pretty much all the time. So strokes. Oh yeah, I'm really glad I'm not a neurologist. Yes.
I had someone on, can you hear me?
Yeah, I can hear you, Michelle.
Okay, sorry. I had someone on Harborview who just had so many different problems, each of which probably would have been solvable by itself. And like, you know, he had came in with uncontrolled HIV. Probably a lot of people already know who this person is because he's in the hospital for like 5 months. And he had like this mysterious lung mass and he kept on getting biopsied. And finally they were like, oh, it's MAC. And ID was like, that's great news. MAC is so treatable. He's gonna be fine. And then my attending was like, but also he's back on dialysis and he's like super cachectic and blah, 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 blah. Yeah, exactly. Multi-morbid. Yes, Dr. McCormick. Thanks, Annie. But yeah, I think that was a particularly challenging one because I think each specialist that was consulted on him was like, oh, well, our particular problem is fixable. But like we looking at him, we're just like, I don't have a good feeling about this patient.
Yeah, and you as the primary team are really trying to figure out really big picture how to take care of someone. And that can be very soul crushing and also just very confusing to figure out maybe what someone's life expectancy is going to look like and what their upcoming life is going to be. So I think that segues really nicely into our breakout rooms. Thank you, Michelle. So I have a few questions for you guys. You're going to break up into groups. And I want you to think about the following questions. Have you ever referred someone to hospice from the outpatient setting? Did you know, how did you know your patient would be eligible for hospice? And then third question is, have there been times when you wish you had suggested hospice and didn't, and why didn't you? So we'll break out into groups for about 7 minutes and then we'll meet back and reflect.
Becca, would you like to join a group?
Yeah, that sounds great. Thanks. I was like, I'm gonna sit here for 7 minutes.
All right, here you go.
Thanks.
She's the first presenter that wants to be in the breakout rooms.
She's so great.
She is really great.
It's funny that like first 2 talks are like pretty thematically aligned, and then I think the last one is like ICU.
Yeah.
Like the opposite framework.
I know. I was like, well, we got a half thematic day.
Yeah. No, but that like is like perfect. So.
Yeah. All right, let me set my timer. 7 minutes. All right, you get a 7-minute break.
Yeah, I might go make more coffee.
Yeah.
Do I have to share my screen again?
Yes, you do. I was just looking to see if you were back.
I'm back, sorry. Ooh, okay. So is everybody, oh great, everyone's back. So I'm wondering if people can unmute themselves, and if you feel comfortable sharing a little bit of maybe some of the themes that you guys talked about in your breakout rooms, what some of your experiences were like, maybe what was hard, why you didn't suggest hospice and you wish you did.
I would just say, I think our group, we were just saying that we've never actually referred anyone to hospice from the outpatient setting. Not because I don't think it's the right place for it. I just think as a resident, I think it's really hard to have enough. I don't have anyone in mind on my panel specifically that I like would refer for hospice, but I think even if I did, the amount of like fragmented periods that were like in clinic, not in clinic, and then we're there like once a month for like half a day. And I know all the competing reasons for that, so it's fine. It's just, I think it's a hard setting to try and have these conversations because I don't envision, since they don't take one conversation in the hospital setting, I can't imagine that it's like a one quick 20-minute visit in the clinic and then you're done and you just move on and refer them. So I feel like it's hard to kind of establish that plan, have already established their trust in forming that plan, and then see them consistently enough to make the wheels turn for that to happen for them. I think, truthfully, I think the outpatient setting is often like the best place for this discussion because it's often with people who maybe have known the patient longer, but it is hard as a resident in primary care clinic.
Totally, Tess. I think I hear you saying that it's very challenging for given the fact that our care is so fragmented, and oftentimes we don't have enough experience with patients, with a particular patient, to make that recommendation and to like make it happen for them. Other thoughts?
One thing our group said is that many times, like I have a couple of people who I've seen referred to hospice, it's someone else who ends up doing it, like the oncologist or the cardiologist or someone else who's really involved in directly managing whatever that life-limiting condition may be, that ends up sending that referral. But I also, I think it was, I couldn't tell who was talking. It was a Tess who was saying that I have like on my healthcare management for all my patients, like advanced directives. And every time I say defer, because I never have time in those visits to actually do anything about it. And if I want to have them come back, as she said, it's like, oh yeah, you can come see me in 3 months when I have 30 minutes on this day. So it's almost useless.
So just not having time, not having it make sense.
Our group talked a fair amount about the amount of privilege that is required to actually enroll in hospice as well, that for folks that don't have loved ones that can act as their caregivers, much less folks who are sort of homeless or peri-homeless, that the people who are providing care for you when you are on hospice are usually your family or friends or other loved ones, and it's usually in your own home. And for folks that don't have access to one or both of those things, it's something that is very hard to engage in. So a couple of our group members talked about specific patients that they've taken care of that would be really appropriate for hospice, but don't really have access to those things.
Oh, Kayla, that's such an important point, that really hospice, it works best for people who are already quite privileged, and we can't get a lot of these services for people who either are alone in their life or are homeless or all the myriad of reasons that you mentioned. I think that's such an important point and a real flaw of the system that we'll talk about. Thank you for sharing that. Any other thoughts, people, before we move on?
Yeah, to piggyback on that, I think the one time I referred someone to hospice, it was from an outpatient setting. It was coming from the family, and it was a family that had, the wife was the patient's full-time caregiver. He had advanced dementia. They had the resources to like pay for like multiple private in-home caregivers. And I just like, he ended up passing away like a few days after the hospice. We actually initiated hospice, but it was like contrasting that experience, which although it was very sad, like the whole circumstance around his death was like very ideal in many ways. Like he was at home, he had all these caregivers, his wife was there. versus like, someone who didn't have all those resources, kind of just put that into stark contrast for me.
Yeah, I think that the hospice working well relies super heavily on someone already having a lot of resources. And it also sounds like this hospice, like the hospice referral happened kind of late, like they died pretty quickly after this was initiated, which is another thing that often happens. And I'll just mention quickly, like Alex said, a lot of times this referral gets made by a subspecialist, which is why part of why I want to do this talk. A lot of people are going into subspecialty medicine, and that's okay. Oftentimes the person who's managing the disease that qualifies them for hospice is a little bit more knowledgeable about the natural course and what might be expected for them. So I think that's okay. Alex also says, plug for homeless palliative care at HMC, and they help with hospice. Yes, that's true. Okay, let's move on. So I think I didn't really get this flavor from people during the breakout groups, but I think that sometimes it can be challenging to think about prognosis from the outpatient setting. It can be feel a little bit vague, whereas in the inpatient side, it's like you see this person who has terrible cirrhosis or heart failure, and you can kind of wrap your head around that they probably don't have very long to live. And so I'm going to point you towards a very frequently used prognostic scale called the Palliative Performance Scale. And this is something that's used by probably most hospices around the country. And that's why I picked this, is because you can refer to it when you are kind of trying to make the case for someone's referral to hospice. And so the way that it works is you kind of go from left to right, and you arrive at a percent, and a percentage below 70 suggests that someone probably has less than 6 months to live. And so, for example, taking Sybil, which is our advanced heart failure patient, we would say she is probably reduced ambulation. So she's already at 60 or 70%. Then you go to the next column. She can't do normal job or work. She probably can't do a lot of housework. So she's still hovering around the 60%. She needs occasional assistance with self-care, or she needs considerable assistance. She said she can't do most ADLs by herself. So she's at probably 50 or 60%. And that's kind of helpful when you're thinking about a person regardless of their disease process. I will say that multiple hospitalizations, that's also something that we can think about when we're trying to see if someone probably has less than 6 months. Any questions about this scale, this calculator? Okay. And then I'll just point you towards UCSF's resource. It's called ePrognosis. And I think part of kind of what we're talking about, or people have hinted at, is that sometimes prognosing can feel different if you're in the inpatient setting versus the outpatient setting. And so they have probably 15 calculators that you can use based on where your patient is. So if your patient's in the hospital, if your patient's at home, if they're in a nursing home, or if they're already enrolled in hospice, sometimes they use particular disease states. And then you basically plug it in, and then they will refer you to one or two appropriate prognosis calculators, which can be very, very useful if you're trying to think about a particular kind of patient based on where they are. Because someone's prognosis might be different based on whether they're in the hospital or whether they're at home. Okay. And then I think it's just like a helpful exercise when you're like, I don't know if this person has less than 6 months. I don't know what calculator I should be using. Just to ask yourself, would you be surprised if the patient in front of you died within the next year? Because I think that's an important thing. I think, like Alex said, we're not so good as doctors at kind of predicting how long someone will live. But I do think that we've got a pretty good gestalt for estimating if someone has less than 1 year. Okay. All right, so let's shift gears a little bit and talk about sort of who is on the hospice team. So kind of like Kayla said, really the center of the hospice program is the caregiver and their elected patient. And then there's a bunch of other people that kind of in the background. So the people that are on the hospice team outside of the patient and their caregiver, this includes the RN case manager. That is a nurse that can help with symptom assessment and management. They will come or call 1 to 3 times a week, not very frequently. There's people called hospice aides, and they can come in. They can sometimes help with bathing, but usually they help with sort of home things like cleaning, cooking, doing grocery shopping. They can also come a couple of times a week. Then you have a social worker that does sort of logistical social worker things. And then you have two doctors, the attending provider and the hospice provider, and we'll talk more about that in the next slide. And then there's sort of these more peripheral people. These include volunteers, therapists, counselors, spiritual care providers, and a pharmacist. And these people are even more peripherally involved, but can provide support in the various ways that you would expect. Okay, let's spend some time talking a little bit about the doctor side of this. So thank you, Alex Adami, for letting me use your picture. So basically the attending physician, this is a nurse practitioner or a doctor that is chosen by the patient. Usually it's a primary care doctor or someone else who's very involved in the patient's care. So that might be a nephrologist, an oncologist, cardiologist. And they're the person who at least initially does most of the work and guides the care. And this basically would be you, unless of course you decided to go work as a hospice doctor. But if you are a primary care doctor and oncologist, kind of managing the patient's medications and care, this would be you. And then there's someone called the hospice provider. And I've used Grady Payton from the VA. I've used his picture just because I just like imagine that if it were Grady Payton, that would be great. He's one of the palliative doctors there. So the hospice provider is basically like a safety net or a secondary check. They are someone who works for the hospice group, and they're responsible for ensuring that the patient gets the appropriate symptom management. And sometimes they can help if you, for some reason, are unavailable. They are someone that the team, the nurse, or the patient can call for a little bit of help. So you're not alone in kind of managing someone's palliative treatments. I think this is helpful for people to know that like you're not the only doctor on the team. So, oh, Alex, okay. Any questions? Looks like Annie has a question. Does hospice provide hospital beds, lifts? Sorry. Yeah, so basically the hospice can usually arrange for things like beds and lifts, and those are usually covered by the hospice insurance benefit. And it can happen pretty quickly.
Thanks, Becca. Yeah, I feel like families often have a lot of questions about logistics of like, how are we going to get him in the house? Where are we going to, but the bedroom is upstairs and stuff like that I didn't know how to answer.
Yeah, and I think that the hospice, like social worker, can be very helpful with those types of things. And the nurse, they are the ones that really manage a lot of that stuff and can be helpful in kind of getting it done quickly. In my experience, that happened with me and one of my patients. Okay. So let's circle back to this idea of the hospice MVP, which is the patient and the caregiver. Like Kayla said, it's really a lot of the care is provided by someone's elected person. And so that means that your patient's enrolled in hospice and either their family or their friend, they are the ones that are administering medications, operating pain pumps, administering tube feeding if someone is maybe transitioning away from tube feeding, bowel care, wound care, nail care. This is all done by a family member or a friend. And sometimes, like I said, a nurse can come in 1 to 3 times per week to help, but really they need to have a full-time caregiver. And that's I think a common misconception that hospice includes 24-hour care, and it does not. Any questions about this slide? Okay, let's move on. So I want people, if you could just type in the chat or unmute, let's go back to Sybil and think about what medications we're going to continue for her. This is her med list, probably a little shorter than most of my patients' med list. Just wondering what would you continue for her? You guys can type or talk. I'll give you 10 more seconds and then I will just do it. Get rid of the aspirin. Kim, are you saying keep the sertraline? Oh, keep the sertraline and the Miralax. Okay.
Yeah, I guess is aspirin and atorvastatin we're investing in sort of long-term benefits.
Yeah, and I think that's a great way of thinking about it. What medications are providing maybe like long-term mortality benefit, which may not be relevant in our patient, and which are providing palliative role.
I think insulin is often one that is insulin and like the VTE prophylaxis meds are often ones that I think get a little bit tricky when you're just trying to consider like actually how long, again, like trying to estimate how much longer people have, because if it's on the really short term and like trying to minimize how many times you're like having to stick somebody with a needle is really nice, but obviously like you don't want them to go into DKA at the end of their life, you know, so it's just this balance of like, is this something that will prevent bigger harm, or can I maybe minimize this or at least like reduce it so that I'm not like sticking them with insulin, you know, 3 different times a day.
Yeah, Tess, that's so great. And I love what people wrote in the chat. I think there's like really a lot of ways to do this. And I've bolded which medications you could argue are reasonable. Kind of, I think Alex said that some of the GDMT might be actually symptom benefiting. And so for someone who's got bad angina, beta blocker could be great. Offloading the heart can make people feel better. Similarly, keeping antidepressants is a great thing to do. I've grayed out the insulin, kind of like Tess said, maybe you decide to consolidate to just a basal and you get rid of the mealtime so that you get rid of maybe people are symptomatic from hyperglycemia sometimes. And then I think 1 or 2 people said that like you talk to the patient and you see like what is really gives them comfort. Things for primary prevention, so aspirin, Atorva, and apixaban are usually not covered. That being said, if someone has like a huge PE, you could probably make the case to keep it on. Okay, so basically, like I said, medications for comfort related to your hospice diagnosis, whether it's heart failure, cirrhosis, and related conditions. So I just thought it'd be useful to go through a couple of common diagnoses and what medications would be reasonable to continue. So starting with advanced heart failure, like our patient Sybil, very often guideline-directed medical therapy is actually approved and covered. Even sometimes inotropes can be covered if appropriate. Things like opioids, SSRIs that have been mentioned in the chat. I will mention that things like SGLT2s, statins, and anticoagulants are often not covered. And some of the other medications, I think sometimes like Entresto is not always covered. Yeah. And then we can talk a little bit about COPD, which is another common diagnosis. As you might expect, inhalers are covered, cough medications, opioids, but things that are often not covered are some of the other fancy medications. Sometimes the vasodilators are not always covered, xanthines, things like that. Yeah. And then when you say covered, can the patient not just continue getting patients through their regular insurance? That's a great question. So it sort of depends. If somebody is over the age of 65 and they're on Medicare, they have Medicare, usually they switch to the Medicare hospice benefit, which basically is their insurance. If they have other insurance that they pay for privately, then certainly they can get whatever medications they want. But that's sort of beyond the scope of my knowledge. I'm not an insurance nerd. That's a great question. Hospice doesn't need to approve them. Like you can continue taking whatever medications you want. Just hospice may not. The hospice insurance benefit might not pay for it. And then lastly, for dementia, things like antipsychotics, anxiolytics are covered. Often things like cognitive enhancing drugs like donepezil and memantine will not be covered. And then, as I mentioned earlier, the hospice team has a pharmacist, and so they can be really helpful in kind of negotiating and figure out what medications might be useful. Or sorry, might be useful, but might be useful and or covered. Okay. And Medicare doesn't have like a strict list that they say they will or won't cover. It can kind of depend on the team and the person. Okay. And I'll just mention this thing called the emergency kit. A lot of hospices have them, especially for people who maybe have dementia or other kind of like I think someone used the term multi-morbidity. They have this thing called the emergency kit, which is basically kind of a goodie bag of symptom relieving medications. And this can be really nice that they kind of show up with on the first day, especially if someone is in the sort of undergoing the dying process, which unfortunately a lot of patients are when they enroll in hospice. And so this is kind of something cool to know about. So suddenly you're not responsible for like ordering a bunch of benzos and opioids, and that can be quite overwhelming. This is a nice resource for people. Okay. And then in our last couple minutes, I just wanted to talk a little bit about caregiver burden, which I think is a major flaw of hospice. I think Kayla and some other people have highlighted this, that really it relies on the unpaid work of families and friends, the majority of whom are women, which is probably not surprising to people reading the news and being a citizen of the world. And really that hospice care actually just amounts to a little bit of assistance in the home. So really just a few hours a week from the nurse, the hospice aides, and some of the other volunteers, and the rest of the care is provided by a family or a family member or a friend. And then I'll also just say that I think that like there is a little bit of trauma and burden associated with managing difficult symptoms at home. I think all of us can appreciate this issue, being in the hospital and taking care of seriously ill patients, that it can be really challenging to manage symptoms for patients who are either dealing with severe pain or dyspnea or any other complicated symptom. And it can just be a big burden to patients and their families at home who may not have a lot of medical experience. And then I'll just say that I think in society today, we have really, I think, swung away from the hospital death to this idea that a death at home is a good death. And I think that we should just be really careful and really thoughtful about that, because that's not always the case. Having someone die at home is not always the safest or the easiest or the most emotionally satisfying thing. Thank you for writing stuff in the chat. Looks like Seth said, eye-opening article on caregiver burden and equities of hospice care during COVID-19. Yes. And I assume we'll talk about this later, but the hospice benefit for caregivers after and around death are a big deal too. Great, yes. I think that agreed with Alex. I think that sometimes the volunteer support, the spiritual care providers can be really helpful after death. That's exactly right. I think it's a couple of months, and I think it probably depends on the hospice group that provides the care. I'm actually not going to talk about this, so thank you. And then I chose not to talk that much about COVID-19, but it's definitely been a issue for sort of access to some of these volunteer services at home. I think there's definitely a lot less of it these days. Okay, great. Thank you all for your really thoughtful thoughts. So just a couple more slides in our last few minutes. I think I'm running a little bit over time, but I'll just quickly review this thing called the Medicare Care Choices Model. I think it's really interesting. It's an initiative that Medicare is doing, partnering with about 100 hospices around the country to sort of trial patients undergoing disease-modifying therapy while at the same time enrolling in hospice. And I wonder if, it seems like they're reducing Medicare costs, people are really satisfied with it. And so it may be that in our careers, the kind of the way that people get enrolled in hospice and have to give up traditionally curative therapies might be changing. And so it's just something to know about. And I think it's pretty interesting. Earlier in our group, we were talking about patients who are on dialysis, and that can be like a big barrier to getting people to hospice. And there are a lot of people who hospice might be really great for. They might be able to get medical equipment at home and other support services that might be helpful for them. And this is kind of a cool model. And then similarly, the VA does something actually very similar. I'm not sure if people know about this, but that the VA has what's called an expanded hospice benefit, which allows people to get disease modifying therapy while at the same time being in hospice. And this isn't really true for most patients in the regular Medicare hospice benefit. And it's pretty cool. We spend less money and people are more satisfied. People end up in the ICU a lot less. And people, still get their things like chemo and radiation, and it's kind of a cool thing. In the interest of time, I kind of won't. Oh, Lauren says you're good. Well, I want you guys to have some extra time this morning, so we're not going to go too much in depth. But this was basically, they studied it in 2019 in JAMA Oncology, and they looked at sort of money spent, patient satisfaction, how many people got in the ICU or had hospitalizations, and all the things happen that you would expect. And I think this is sort of interesting. I'm hopeful that maybe one day the hospice enrollment doesn't have to be an either or type of thing, but that there can be a little bit more of an overlap between disease modifying therapy and hospice. Wow, Cody, thank you for sharing that perspective. Just the sort of the challenge of being a hospice care provider for a loved one. I don't think we can begin to understand it. And so, yeah, thank you for sharing that personal experience. Okay, so I guess we are going to end a little bit early today. My key takeaways are that hospice is not a place, but rather a bundle of services provided by a hospice insurance benefit for patients with an expected prognosis of 6 months or less. And that hospice care relies super heavily on unpaid family and friend caregivers, which is a major flaw of the system and definitely excludes a lot of people who are under-resourced. Inpatient hospice care is super limited, but short respite stays are sometimes covered for aggressive symptom management and to reduce caregiver burden. Intentional medication reconciliation is necessary for patients enrolling in hospice, and several initiatives exist, like the ones I mentioned, the Medicare Care Choices Act and the VA Extended Hospice Benefit, that are looking at concurrent hospice and disease modifying care. I want to thank Hillary Iskin, Molly Kelly, and Jody Waldron for helping me with this presentation, and happy to take some questions in the last couple of minutes. Oh, and Alex Adami for being a model. Okay.
Yeah, thanks, Becca. I just wanted to share, I think what you had talked about at the end of when it's okay to have people die in the hospital, which I know this was supposed to be about outpatient, but so often we deal with this in the inpatient side, where I felt like, especially during COVID, that I've been like really pushing home hospice because that would allow more family members to see a patient. And I had a patient who was just like, I don't want to be this burden on my family at home. I don't want to have to ask them to take care of me. And I felt like I was really trying to convince them that, no, your family wants you to do, like, wants to see you, wants this. And them was feeling like, I think there's a lot of transference here. Like, I really want your family to see you, but is that what you want? And yeah, that's really hard.
Yeah, thank you, Annie. I think you're so right. And I've had experiences where patients say, I want to die in the hospital. I don't want to die at home. I don't want my family to see it. I want my home to stay my home and not this place tarnished by my, impending death. Like and if only we had unlimited resources where people could all, die where they want to and families would be satisfied, but we don't. And it's emotionally challenging for us too to see patients die in the hospital. It's emotionally challenging for everyone. So yeah, thank you, Annie. Any other last minute thoughts? Okay, thanks everyone for listening.
Thank you,
Lauren.
Becca. That was great. So interns